up, let's talk about basal cell carcinoma now, which is the most common type of skin cancer. And from the exam point of view, very important question as well. Basal cell carcinoma is a malignant neoplasm which arises from the basal cells of the epidermis. That's where the name comes from. Stratum basal or basal cells of the epidermis may convert into a type of cancer, which is known as basal cell carcinoma. Some synonymous terms exist. It is also known as basal cell epithelioma, basilioma, or rodent ulcer. Now, among them, the term rodent ulcer is very commonly used. Okay, remember the term rodent ulcer. This is another term for basal cell carcinoma. Advanced type of basal cell carcinoma is known as rodent ulcer. Most basal cell carcinoma are caused by sunlight-induced damage to the skin. So this is an important risk factor. If somebody is exposed to sunlight for a long time in their life, then they may suffer from basal cell carcinoma. And of course, it is the most common skin cancer. Let's move on. Now, let's see some of the picture here. This is basal cell carcinoma, okay, on the face. See this? This is a nice ulcer formation, but still it is not called as rodent ulcer. Okay, a rodent ulcer looks very severe than this. This is another type of basal cell carcinoma. There are different types, we'll talk about that later. See this? Here is another one, basal cell carcinoma. These are a little bit more severe looking. See this? Okay, a bit of magnified view, the same patient maybe. Now, basal cell carcinoma occur predominantly on the head and neck area. Head and neck area, especially on the head, in almost 70% of the time, predominantly on the head. 25% on the trunk and 5% on the penis, vulva, or even perianal skin, because squamous epithelium is present in these areas, and the downmost layer of that epidermal part of the skin there is basal cell. So any cancer which occurs from those basal cell is called basal cell carcinoma. That is the point. That's why it can occur in this site. But remember, most of the patient presents with facial involvement. Very rarely other organs are affected. Now, the important part, what is the etiology? Why this cancer develops? The exact cause of basal cell carcinoma is unknown, but there are certain hypotheses, and they are environmental and genetic factors, like radiation exposure. Okay, probably the most important one, radiation exposure. This radiation is coming from sunlight. You can also call it ultraviolet rays exposure. Okay, UVR. Mutation of the gene, genetic predisposition, exposure to X-rays. Somebody is working in the hospital or clinic where X-ray investigation is being done, and if they are exposed themselves to X-ray for a long time. Arsenic exposure. Arsenic is a type of metal. Immunosuppression. Any immunosuppressive condition, a chronic type. Xeroderma pigmentosum. Okay, a type of genetic disorder which runs in the family through autosomal recessive inheritance. Okay, and a lot of features are present here. We'll talk about that a bit later. A few important points will include definitely. And then epidermodysplasia verruciformis. Now you are quite familiar to this term, I suppose. What is this? Anyone? What is this epidermodysplasia?
Severe type of viral wart caused by HPV.
Very good. It is the most severe type of viral wart, which is caused by human papillomavirus. This is also autosomal recessive inheritance, which may run in the family. Okay, and in this condition, there are many warts occurring in the body. It's very difficult to cure or treat. At the same time, different type of skin cancers can occur in the patient. Now, a little bit explanation for each of these etiology so that you can remember this for a longer time. Sunlight, okay, especially the ultraviolet rays, which is present in the sunlight, and if it is a chronic type exposure, is the most frequent association with development of basal cell carcinoma. The risk correlates with the amount and nature of accumulated exposure, especially during childhood. Now see this. This is a very important point here. Accumulated exposure. More the patient is exposed to the sunlight, means longer and more amount, then there is higher chance. A latency period of 20 to 50 years is typically present between the time of ultraviolet damage and the onset of basal cell carcinoma. So 20 to 50 years, it's a long gap. Both short wavelength ultraviolet B radiation, this is a wavelength of ultraviolet B, 290 to 320 nanometer, and longer wavelength ultraviolet A, like 320 to 400 nanometer. So this ultraviolet B radiation is also known as sunburn radiation, and ultraviolet A is known as tanning rays. Okay, tanning rays. It is quite a popular term. Okay, in those people who are having fair skin. Okay, especially the Caucasians, because they want to tan their skin. They don't like that white looking or very fair looking skin. They want to convert their skin in relatively brownish or even a bit of pigmented type. So they expose themselves to the sunlight just for the tanning purpose, and over a period of time this can act as a very important risk factor for the development of basal cell carcinoma. Let's move on. Now, another important, etiology or hypothesis here is gene mutation. Okay, gene mutation. Serious. Recent study demonstrate a high incidence of TP53 gene mutation in basal cell carcinoma. So this is a type of gene which is mutated, and ultraviolet sunlight may play an important role in the genesis of this mutation. So again, there is a role of sunlight exposure. Other radiation exposure like X-ray, already talked about, may be a cause, and arsenic exposure through ingestion may be a cause. Arsenic may be present in the water which we are drinking. Okay, that's why before before labeling that water as a safe water to drink, different type of test should be done. Okay, some heavy metals may be present in that water, and that presence of the heavy metal may not make that water safe to drink. One of that heavy metal is known as arsenic. Immunosuppressive conditions are another important risk factor for the development of basal cell carcinoma, and that can be easily explained by recipients of organ or stem cell transplant, and even the patient with HIV and AIDS may develop basal cell carcinoma. And the connecting point there is immunosuppression. Skin cancer incidence is 10-fold higher in the transplant patient than in the general population, and up to 65 to 75% of the patient with long-term immunosuppression develop skin cancer. So there is a definite connection between immunosuppression and different type of cancer. Remember, this is just one type of cancer we are talking here, okay? But the same patient may be develop lymphoma in different organ. These are non-Hodgkin's lymphoma, which are strongly associated with the degree of immunosuppression. Now, Xeroderma pigmentosum is one of the important risk factor. It has a very high risk of developing, basal cell carcinoma in this condition. Not only basal cell, other type of skin cancer can also occur. So this is autosomal recessive disorder, which results in the inability, to repair the ultraviolet induced DNA damage. Now let me clarify this a little bit here. Our cells have a special, a property. They can repair the damage done to the cell. But there are certain situations where that cannot happen. Okay, one of them is xeroderma pigmentosum. It doesn't allow the repair of those DNA which are damaged. So if DNA remain damaged and there is easy mutation, and that mutation can lead to different type of cancer development. In case of xeroderma pigmentosum, the pigmentary change are seen quite early in the life, followed by the development of basal cell carcinoma, cutaneous squamous cell carcinoma, and malignant melanoma. Okay, so these are the risk factors. Other features include corneal opacity, leading to eventual blindness, and even the neurological deficit. So these are the factors which help us to diagnose, yes, this is a patient of xeroderma pigmentosum. Corneal opacity can happen, blindness, and even neurological deficit can occur in case of xeroderma pigmentosum, serious type of situation. Now, another is epidermodysplastic or dysplasia verruciformis. This is again autosomal recessive disorder where, a person is infected with human papilloma virus, and this is a very severe form of wart, and this can easily convert into different types of skin cancer, mainly basal cell carcinoma and squamous cell carcinoma. Now, after talking about those causative agents or causes, what is the clinical feature of BCC? Now, let's start with the symptom first. See here. Patients presenting with basal cell carcinoma often report a slowly enlarging lesion that doesn't heal and that bleeds when traumatized. Probably the most important clinical feature is this. So how the patient complain? Doctor, I'm having this lesion on my face for many months. Okay, it doesn't grow that big. Okay, it is not healing at all. I'm having this for many months now, and when I touch it, it can easily bleed. Okay, this is a very, very common symptom. As tumor most commonly occur on the face, patients often give a history of an acne bump that occasionally bleed. So patient confuse this, a basal cell carcinoma lesion with acne vulgaris, or a small acne bump. Bump means swelling there or nodule there. Acne has a different type of manifestation we have studied before. So they may confuse this with acne, and they don't come to hospital in time also because of this. But after many months, when it doesn't disappear, it still remains there. That patient may be suspicious. Maybe this is something else, not acne. So they may report to the doctor then. Consider basal cell carcinoma in any patient with a history of sore or skin anomaly that doesn't heal within 3 to 4 weeks, and especially if it occurs on sun-exposed skin, especially if it is dimpled in the middle. These are some other features. Means not healing in time, especially occurring on the sun-exposed skin, like face, like the back of the hand, upper part of the neck. These are the areas. And if it is dimpled in the middle, then it has a higher chance of being a basal cell carcinoma. Later on, we'll talk about what the different type, so you can easily understand. This tumor may take many months or years to reach even 1 centimeter in diameter. Very, very slowly growing tumor. Though they are malignant tumor, they are behaving like a benign one here. Now, during physical examination, what are the characteristic features? See here. The characteristic feature of basal cell carcinoma include the following: waxy papule with central depression, okay, pearly appearance, erosion or ulceration, which is often central part of the lesion, bleeding, especially when traumatized. When the patient, itches there, for example, patient has a bit of nail there, a longer nail, and when they develop slight itching, they may scratch there. That can lead to quick type of bleeding. Crusting on the surface, rolled or raised border. Okay, this is an important feature of malignancy: raised or rolled border. Telangiectasia over the surface means development of new blood vessels over the surface of the nodular mass, and very slowly growing, 0.5 centimeter in 1 to 2 years. It's very, very slow growing. So these all features may be there, as some of them may be present in some patient and other may be present in other patient. So this is the meaning. Now let's see some of the picture and try to correlate the physical findings here. See this. This lady is having features here. See this, the lower eyelid. Look at this area here. A small swelling I can see, and a small ulcer also I can see here. Now on the upper eyelid. Now nobody can diagnose it as a basal cell carcinoma at this stage. Very difficult one. The first thing which comes in our mind, you have not gone through ophthalmology. There is a term known as chalagion. Okay, chalagion. In the eyelid, we have got meibomian gland. So if that meibomian gland duct is blocked, okay, there is a cyst formation, which is known as chalagion. It almost looks like that, chalagion. Okay, and if it is very painful, we call it stye. Stye is staphylococcal infection of the lashes here. Okay, so those are the common things. We always think about them first. But if the patient is continuously having this feature for many months, then we can think of basal cell carcinoma. Basal cell carcinoma occur mostly on the face, head, neck, and hand. Already talked about. The lesion grows slowly. It is not painful and it doesn't itch. It doesn't itch, but sometimes, a patient feels there is a slight amount of itching there. Okay, sometimes it may be a subjective type of feeling also, and during that process, they may traumatize that area and it may bleed. Periocular tumor most commonly involve the lower eyelid, followed by the medial canthus of the eye, then the upper eyelid, and the lateral canthus, okay, in a decreasing order. So the most common one is the lower eyelid, followed by the medial canthus, then the upper eyelid, and the lateral canthus. Now let us go back to that picture again. Let me show you what are these important site there. Okay, see here. So here is a lower eyelid. Okay, lower eyelid here. This is known as medial canthus. This is the angle, okay, formed by upper eyelid and the lower eyelid. This is the canthus. It's the medial canthus. Here is the lateral canthus. So lower eyelid is the first, medial canthus is the second, upper eyelid is the third, and lateral canthus is the fourth in the decreasing frequency. Now, several different clinico-pathological types of basal cell carcinoma exist. Okay, and they are nodular, infiltrative, micronodular, morphiiform, also known as sclerosing type, and superficially spreading type. Now see there, nodular type, which may be cystic, pigmented, or keratotic. Okay, so all of these are nodular type. Infiltrative, micronodular, smaller in size, morphiiform or sclerosing. That's why, at the center there may be depression because of the sclerosing type reaction. and then superficial. So let's talk a little bit about them with the help of picture. See here, this is the nodular basal cell carcinoma. Okay, nodular basal cell carcinoma, like this. It appears as a waxy lesion, translucent papule with central depression, and a few small erosion. This is very typical of a malignant lesion here, but it may take a longer time to develop this type of lesion, so presentation is late, but we don't need to worry. Even if the patient comes late in the hospital, this disease doesn't kill them. This is a superficial basal cell carcinoma, superficial one. There is another one. It is very easily confused with some other lesion on the skin. This one also. So biopsy should be taken. This is a pigmented basal cell carcinoma. It is very easily confused with melanoma. Okay, melanoma, the most lethal type of skin cancer. So biopsy will differentiate between them. This is known as infiltrating or morphiiform basal cell cancer. Infiltrative or morphiiform. Look at this area, this whole area actually. And these are telangiectasia, the dilated superficial blood vessels. Telangiectasia. Okay. Another one, morphiiform, in this area. See this? Very typical. Look at the fibrotic reaction type in this area. It has clear border here. See this? This is the border. And I can see the dilated blood vessels on the surface. Now, if we take a biopsy, okay, then how does it look like? This is a histology of basal cell cancer. See this? This is a flex of the keratin on the surface. Okay, this is the epidermis. Look at this area here. See here. Okay, there are a clump of the cells. Looks like a tumor. Okay, and it is originated from the basement layer. So basal cell carcinoma. This is advanced basal cell carcinoma, which is known as rodent ulcer. See this? It has a property of local invasion and destruction. And this takes many years to develop. Remember, it doesn't metastasize, but it has a property of local invasion. And the advanced type of basal cell carcinoma, which causes local destruction, is known as rodent ulcer. So let me write that term here. Rodent ulcer. Very important MCQ question for you in the exam. Now, how we are going to treat? Okay, what is the treatment of basal cell carcinoma? The recommended treatment modality is surgery. So surgery is the best option we have. The surgical approach varies according to tumor size, according to tumor depth, and according to tumor location. What type of surgery the surgeon do depends on this factor. One of the important types of surgery they like to do is known as Mohs surgery. Okay, this Mohs surgery is a precise surgical technique which is used to treat skin cancer. So what they do in Mohs surgery? Here, during Mohs surgery, thin layers of the cancer-containing skin are progressively removed and examined until only cancer-free tissue remains. So this is a layer by layer type of removal. It is not at one time the whole area is removed from there. Not like that. Layer by layer removal is really important here. So because of this, it is also known as Mohs micrographic surgery. Another type of treatment is a local therapy with some chemotherapeutic agent and immunomodulating agent. It may help, like topical 5% imiquimod can be used for the treatment of non-facial superficial basal cell carcinoma that are less than 2 centimeter in diameter. And in some other patient, we can go for topical fluorouracil. Okay, topical fluorouracil. So just sometimes they may ask, these points in the MCQ question. Just try to remember the name. 5% imiquimoid and topical fluorouracil. In comparison to the Mohs micrographic surgery, they are very less commonly used. The third one is radiation therapy. Now, an important point here. Prolonged radiation therapy itself can lead to basal cell carcinoma, but for the treatment purpose, radiation therapy can be used. But what may be the indication? This is a primary treatment option in patients who are not surgical candidate. We cannot go for surgery in certain individual. Okay, the surgery is contraindicated in them, or sometimes people may not go for surgery. Surgery, is very scary to some of the people. They are really afraid of the term surgery or operation. So it may be the option in them. Now, regarding the prognosis of basal cell carcinoma, the prognosis for BCC is excellent, with a 100% survival rate for cases that have not spread to other site, isn't it? So this is a 100% survival rate. Although basal cell carcinoma is a malignant neoplasm, it rarely metastasizes. So I've been talking about this term from the beginning of the class, and here it is. The incidence of metastatic BCC is estimated to be less than 0.1%, very less. Typically, it is a locally destructive tumor though. That's why rodent ulcer will be developed. Now, look at the prognosis of this treatment. Different types of treatment can be used in case of treatment purpose. So 5-year recurrence rate for primary basal cell carcinoma, previously untreated one, is as follows. See here, surgical excision 10.1% 5-year recurrence rate, so not a good one. Radiation therapy 8.7% recurrence rate. Curettage and electrodesiccation 7.7%. Electrodesiccation means destruction of that site with the help of electrocautery. Cryotherapy, okay, cryotherapy means cold therapy, especially by liquid hydrogen and carbon dioxide, 7.1% recurrence rate after 5 years. All non-Mohs modalities 8.7%, and Mohs micrographic surgery has 1% 5-year recurrence rate. So easily any student can tell what is the best option for the treatment. That is Mohs micrographic surgery. So different type of options can be given in the exam. So please remember this name here. Okay. So at the end, I like to request you all to like the video as much as possible, share it among your friends, and subscribe to the channel so that it will encourage me a lot for the future videos and recordings. Thank you so much.